So this stuff, you probably know better than I do at this point. And I proved this to myself a few weeks ago, and I responded to, I didn't respond, we were driving to Seattle to pick up a puppy, and 30 miles out of Spokane, we just see this rolled over car in the ditch on the other side with all these bystanders just looking at something in the grass 50 feet away from the car. There's nobody on scene, no ambulance, no fire, nothing. And my wife's like, we should probably stop. Yes, we should probably stop. So it was my first time as a first responder in a true, in a true trauma bad scenario. And I critique pretty critically of myself, and so I overall passed the scenario. But I failed miserably at scene safety, I think. I failed there. And I definitely failed at figuring my best transport medium. So I proved to myself that you can prepare all you want and teach this stuff, but when the rubber hits the road, you're not going to be perfect virtually every time. You're going to miss some little stupid thing. As you get further in your career doing this more often, yeah, you're going to get better and better, but then you'll still have something on that call you could have improved. I should have activated the damn helicopter. The guy would have been the same, but I should have activated the helicopter.
So you're saying there's a difference between clinical and field?
Huge. Would I ever, and you guys, you all get amazing respect from me, and I will never chew you out in the ER, because I know that when you bring them to me, I have my nice clean ER, I have nurses to help me out, I've got techs to help me out. You're bringing me a patient that, while they still might have feces and urine on them, they're not laying in it. And you had to pull them out or do CPR in their bathroom, and feces on the floor and vomit, and family and the dog barking at you. And yeah, I'm glad I'm not there. You guys are awesome. You guys are awesome. And now you're all quitting. No, you guys get to do, and you get to do most of the fun stuff. And as paramedics, you take a lot of the fun stuff away from me. And by the time you bring it to me, I go, shit, there's nothing for me to do. I just got to admit them. And it kind of takes some of the fun stuff away. So you'll come in with needles in the chest and IVs started, and you'll have the diagnosis already. You're already giving them medications. And you'll be doing some amazing stuff that really leaves the ER doctor with, I got to do something to make it look like I'm valuable here. So yes, kudos. You'll do some cool stuff and you'll enjoy it. All right, so you know this stuff better than I do. The scene size up and primary assessment. So all I can tell you about primary assessment and secondary. Primary should take you no more than 10 seconds. It's truly dude, they're breathing, they got a pulse, we're good, right? Or they're not breathing, they don't have a pulse, start CPR. I'm still in my primary survey, and I'm not moving to secondary until I either have help or we're just doing the process and things are moving along. The secondary survey and this is combined. This, I think, goes in your secondary survey. Because your primary, you've already confirmed that they're either breathing and have a pulse, or other people are taking care of that with CPR. And I now have time to do something else. Somebody else is setting up the defibrillator. I'm going to do a secondary survey. And the secondary survey is truly your head-to-toe detailed exam, where you're looking and feeling everything, finding the injuries that are not seen initially. So like that rollover case I came across, I did do a good secondary survey. The guy's laying on his right side, he's moaning, his eyes are open, he's drooling, he's got blood coming from the ear, he's got obvious head trauma. I mean, I knew right off the bat he's got brain damage, he was thrown from the car, this is an easy one. He's not going to survive this. But then, while we were just maintaining things, I did a good secondary survey, and it was fun. I found sub-Q emphysema, goes along with the pneumothorax, air in the chest wall, feels like Rice Krispies. He had a flail chest. So he had reciprocal movement of his chest wall on that side where there's all the emphysema, and he moaned more when I touched it, and I felt crunching, so I knew there was rib fractures, a pneumothorax, a flail chest. So that was cool. Went further down, and I found under his pants he had big edema, chronic-looking edema. So now I'm like, this isn't your normal guy. He's 30-something probably. Huge edema. So I'm like, there's some chronic medical conditions. And then I found the antecubital nodes. And I thought, he's a naughty guy. So there's a lot of things about him that he found in the secondary survey that then I called into the ER, and I was like, this is more than just a rollover ejected with brain damage. He's going to have flail chest, pneumo, get the chest tube set ready. He also has a broken leg, and he's got edema and track marks, so just FYI. And let's see, So you can size up. You guys know this stuff, right? This is stuff you're already doing. And I always wear gloves with every single patient. I actually don't shake patients' hands anymore. I try not to. And it's not to insult them. It's more of an infection control measure. If they put their hand out to shake it, I shake it. Totally fine, but then I wash my hands right away and then put gloves back on. Okay? Or I shake it with gloves on. But then you got to be careful. Now you shook their hands, now you touch your stethoscope, and your stethoscope, does that get cleaned after every patient? Maybe. And then you find out later they have C. diff and they shit on their hands. So you got to be careful, okay? So obviously, be like these cool dudes with, I think they have Pearson shirts on from Pearson, and you can't see it here. That's a picture of puppies. They're like little beagles. And if they have a little picture of beagles in their ambulance, I'm really questioning if these guys are up to it. So mechanism is always important, making sure you're safe. This will determine the time elapsed between injury and the patient evaluation. That's great and all, but really where we care about that is strokes and cardiac arrests. So obviously stroke, we want on time of onset, time lasting normal, but also cardiac arrest, how long were they down before anybody got to them, or was the family just staring at this dead guy on the floor and called you and you get there and nobody's touched them? That's important to know. This is questionable.
Essential.
So there was some research actually done, I think by paramedic students or some ER residency medical doctors several years ago, where the research study was really cool. So the research people went into a room, had this fake living room with carpet, and they dumped a bunch of fake blood on the floor and measured them out. And then they had trained EMS providers come in and estimate the blood loss. Sounds cool, right? How do you think the results were?
They estimated a lot more than it was.
They were horrible, way off. They're like 3 liters, 5 liters. The body's got like 5, and so they're way off. And so really, it shows you that blood looks bad in any situation. It doesn't soak into things. It's thick. It'll sit on the floor. It looks, and who's used to seeing blood in this huge swath on the floor? Nobody. It's like not even a horror movie. So when you come on scene and see that, people aren't used to it and they overestimate because they think this is bad. So usually it's a gross overestimation of truly how much blood loss there is. So I actually don't care if people come in and they're like, there's like 500 mLs on scene. I'm kind of like, there's blood on scene. Okay, got it. And it looked to you like there's a lot. Good. All right, so anticipating shock. You're starting to learn that, know the signs and symptoms. Your primary assessment, short, sweet, figure out what's going on. AVPU scale versus GCS. Do you know what those are? Alert, verbal, pain, unresponsive, and the GCS. GCS is kind of a tough one. I'm glad it's on the run sheets. If you asked me to write on the fly estimated GCS in there in the middle, that's tough. I need my calculator, I need my phone, whatever it is, because I need something to write on, and I could figure it out pretty quickly then, but I'm not going to be able to say, oh, on the fly, there are 9. It's too hard in the middle. I can tell you 14, 15, and 3. What's the lowest?
3.
Thank you. Never say 0, because then we won't think you know what you're talking about. All right. And CAB, this is all very simple stuff. You guys know this stuff, right? Okay, rapid assessment. Secondary, this is truly your head-to-toe exam where you're going head to toe and look at everything, feel everything, push on everything, try to move it a little bit. This is where you find the injuries that other people won't find, or it might even miss. ER doctors, all of us have missed injuries. Okay, a trauma patient comes in, they can't talk to you, they're intubated, we get them resuscitated, we get them stabilized, and we do a secondary survey. You're pushing all over there. CT scans ready and waiting. The surgeon's like, let's go, we got to get in the OR. And you're trying to do a secondary survey, trying to find everything. There's just not enough time, and you find out later, oh yeah, there's a broken wrist that we didn't splint. It's kind of like, well, did you have enough time to really do a good secondary survey? They take time. A good secondary survey, it's not 20 minutes, but it takes time to push, feel, look at everything, check their mouth, go down their neck, heart, lungs, sounds, belly, push everywhere. Look at the belly for trauma and bruising. It tells you if there's internal bleeding possibly. Push on their pelvis, wiggle their hips a little bit, push on their femurs, knees, all the way down their ankles and feet. It takes some time. Checking pulses, look at their back. So It's nice not to miss injuries, and it makes you look great. That's all self-explanatory, this easy stuff. Pneumothorax spelled wrong, that's fine. Yeah. And remember, what's pericardial tamponade? What are what's the triad? Good. Muffled heart tones, hypertension, BVD. And you'll see that and get tested on it more than once in your life. Okay, people somewhere will ask that. The pelvic and femur fractures, you ever hear about fractures and injuries that can hold blood. You can hold a pretty considerable amount of blood in your chest, although that patient's going to show it. Short of breath, like cramp, chest pain. The pelvis and femur area, they can hide a lot of blood that the patient and you won't really be able to tell what's going on. They may have a fall with, broke my hip, I have hip pain, I hurt everywhere, but you won't know that there's a liter of blood sitting in their pelvis. It's really hard to find. It just fills up in there. There's space. There's space for blood to kind of collect. You even might push on them. They'll be tender, but it's not like you're going to feel a distended belly with like liquid in there. It's not like that at all. Just know that if somebody fell off their ladder putting Christmas lights up and you check them out on scene and they have horrible pelvis pain and maybe a broken leg and they're hypotensive, tachycardic, look pale, it's more than just a broken leg, far more than a broken leg. Get them into the ER right now. They may be losing blood internally, and at some point they're going to do this when they've lost that reserve tank and now they're crumping on you. And that you don't want to have them in your hands in the ambulance when that happens. Because what they need is surgery and blood.
Going back to sex triad.
Yeah.
So JD, muffled tones, muffled heart tones, and hypotension. I mean, that's like a million things right there that could be. What exactly?
The muffled heart tones. Why do you get that?
You got fluid in there, or your heart?
Yeah. And so really with a lot of things, you're not going to get muffled heart tones. You can have a almost coding cardiac arrest patient with a heart rate of 28. You'll still hear the heartbeat 28 times a minute, but you'll still hear it nicely. But those patients that are thin, there's not a lot of fat in the chest wall, and you put your stethoscope in, you're like, what the hell is that heartbeat? You feel a radial pulse, you feel it carotid, they're even talking to you. My stethoscope's right there. I can barely hear it. That's muffled heart tones. And you're going to recognize, you're going to be like, my stethoscope not working? Like, I can barely hear this thing.
So what is it indicative of? Sex triad?
Pericardial tamponade.
Okay.
Just think of basically that a huge insulating layer around their heart and you can't hear it.
Okay, I just missed
Yeah.
it.
So we know the blood loss, and the pelvis, fractures. Yeah, so this is pretty accurate. You got a sepsis patient, a slow GI bleed, all that stuff, the pale, the diaphoresis, that takes time. Like a GI bleeder or a sepsis patient can take days. And so what's one of the first things that we typically will see though? Kids especially, remember this with kids too. Tachycardia. A sick kid will be tachycardic first. And so you give me a kid that's got a little tachycardia going on, who's laying in his mom's arms, just hanging out, I know something's not quite right. And in pediatrics, tachycardia is a big first finding in a lot of things. I learned that from my wife. Just kidding. We already talked about neurogenic shock, the focused trauma assessment. You guys know what that is, doing your primary and secondary. While yes, that second point, focusing, examining the injured area, is important, you don't want to put blinders on, right? You don't want to put the blinders on and then miss the other injury. It's always embarrassing to come in with that trauma patient who, at home, got stabbed by his girlfriend, or brother-in-law who's sleeping with his girlfriend, and blah, blah, blah. He got stabbed, he's a knife sticking out of the chest, and he's breathing okay, and you completely fail to see the stab wound in his spleen down in the belly. So do a good secondary assessment, because while the initial injury, the arm ripped off, may look really bad, and everybody's like, wow, look at that arm laying over there. Don't miss the other injuries, okay? So do a good secondary survey. We went through that. Clammy skin, bad. Diaphoresis, bad. Orthostatic hypotension, that's pretty common, very common. You'll see it in teenagers who are sick. They'll have a syncopal episode at home. Family freaks out. They twitch a little bit or without their seizing. Very normal when they pass out. It's from orthostatic hypotension. They're maybe under the weather. Their reserve tank is low. They're laying on the couch a long time. Blood pressure. was nice and even keel. They got up too quick to get the phone. Punk. Go down. Very common. Classic scenarios, the Sunday morning at church, little old person who doesn't get out much. They go to church every Sunday. They got up, went to church, passed out in the pew because they do the sit, stand, kneel thing. Okay? So very classic Sunday morning call. But also it can be seen if somebody's reserve tank is low from shock or sepsis.
So it's not always from bleeding internally?
No. Anything that could make your blood pressure low. Dehydration, medications. Somebody's medications need to be adjusted. They're on too much blood pressure or heart rate medication, and they can't compensate. And so anything where you can't compensate well. Let's see, reassessments are important. So in your critical patients, reassess at least every 5 minutes, if not more. Stable patients, 15 generally, maybe even longer if they look great. Okay. But typically within 15 minutes you're going to be bringing them in. Is anybody here going to be working very rural? We're at. How far away from urban?
From like Spokane?
Mm-hmm.
Almost 30 miles.
30 miles, okay.
130 miles.
130. So you're going to be looking at either a lot of helicopter or
We
long,
want to
okay.
a lot out there.
So if you are transporting, that's going to always be interesting of that gray zone patient of, gosh, they're kind of sick, but they're really stable. Do we transport them by ambulance or helicopter? That'll be a really big thing to think about at every topic you go through. Would I transport that patient by ground or air? I generally err on the side of safety, and if they look really sick now, they're probably going to look worse in 10 minutes.
We have long response times too, so a lot of times we want before we ever even get there.
Perfect, yeah, smart. Let's see. That stuff's all easy. So managing hemorrhage. How many of you are going to have blood in your ambulance? Right? So hard to give if you don't have it. So what you're going to want to focus on is direct pressure, pressure bandages, tourniquets, elevation, pressure points, fluids, and then blood pressure support if you need it. Splinting is always good as well, but be careful if you move the injured extremity too much, you could cause more damage or disrupt the clot and they bleed more. This stuff again is with every patient. IV, O2, EKG, scene safety, simple stuff. We already talked about direct pressure. So where do you not want to give direct pressure, obviously? Sorry, I'm going to put this tourniquet around your trachea. That'd be kind of fun. But, no, open skull fractures. Probably not a good place to push, right? Kids' head injuries, neck. Okay, any place where you can't push. Carotids, not good to make a patient stroke, right? Eyes, you're not really that often going to have hemorrhaging from the eyeballs. If that's the case, you're probably looking at Ebola and you just need to step back. So obviously places you don't want to push on. What are things we could do to these places then? Head wounds bleed like bad, right? All those capillaries, what can you do?
Elevate, cover.
Yeah, you can still put pretty good dressing wrap on, almost a little pressure-like dressing. Just be careful. If you think it's truly a depressed skull fracture, be very, very careful.
In the book, talk about where the skull is still stable, making a ring and holding pressure further away from the injury site.
Yeah, you can do that. Generally, just a nice pressure bandage of 4x4s and a head wrap is fine. Nice thing about the head, there's little arterioles and capillaries. That's why it bleeds so much, because you have more blood in places that grow a lot. Okay, if you're unlike me and you actually have a good head of hair, there's a lot of blood flow going to the scalp because there's constant growth. There's a lot of blood flow to the intestines. There's constant cell growth and turnover. So places where there's lots of cell growth, turnover, lots of blood flow. So that's why the head is covered in capillaries and tiny blood vessels. The nice thing is there's not a lot of giant arteries. You got this one going up here on the outside, and then inside the skull there's one. But up here, there's no major arteries. So while there's lots of blood from all these capillaries, it's generally easy to stop if they have an intact skull. If there's no skull fracture, little bandage, even on a giant head wound, it'll stop it. Splinting, that's easy. You'll go through that. The pressure points and elevation. Know your easy pressure points: femoral artery spot, popliteal artery behind the knee. That's harder. I usually go for femoral if you really need a spot. Brachial we talked about. Don't really push in the carotid a whole lot. You're only going to stroke the patient. Hemostatic agents. Anybody had any experience with this, military or other? They're cool. All right, quick clot. Cops got it. See it in movies.
Been on one where, and it was kind of interesting because it just filled up the hole and we had a lot to clean out. It looked like little PDs everywhere. Does it affect the wound when you guys deal with it, or?
We don't really do a lot in the ER. This is more of a in the field, on scene.
But I mean, we clean it out when they dump it
Oh.
all in there, or?
Yeah, we'll irrigate it. It's not hard to clean out, and as long as you stop the blood, some people might get all pissy and annoyed if they got a dirty wound or a surgeon, but the fact is they weren't there on scene and saw how bad it was, or what you tried to do to fix it first, whether it was direct pressure or other pressure bandage. So if you had to use it, I'm not going to question you. And then now if I just got a wound that needs to be cleaned, who cares? Better that than a gushing bleeder that I have to give blood to. There's different kinds of hemostatic agents, and there's desiccants, and their job is to kind of pull the fluid. It's like a desiccant packet out of something you ordered in Amazon, and it pulls the fluid out and it helps absorb the fluid, and so it makes the blood stickier and it clots better. There are things that actually have factors, clotting factors impregnated into it. There's bandages you can buy. There's also this new injectable, weird-looking dealio. It's like a big, thick syringe. You actually shove it into the bullet hole. It's made for bullet holes in military application. You carry this injectable syringes like this, long and that big around. Keep it in your pocket somewhere in your trauma gear. And the syringe is not filled with fluid. It's filled with these little white pellets. And those little white pellets are both foamy. They expand. They'll reabsorb into the body. They dissolve. And they're impregnated with a clotting substance. So you shove it in the bullet hole, inject all these pellets, they fill the wound, they start expanding, and they have these clotting elements built with them. Kind of a new thing, but really it's perfect for a gunshot wound, stab wound. Other than that, really not useful.
You said that you'll work to Mexican nationals up through coffee grounds, and any idea why?
Coffee grounds?
Yeah. Thought that you might know. We never understood, so.
Yeah. I don't know the coffee ground one. I can't think of anything in coffee that is a clotting or desiccant or coagulant.
Okay.
Sounds cool. Maybe they're getting confused with gunpowder. I don't know.
But you-
Gunpowder would work, right? You gotta light it. Ouch. Burn the wound shut.
The injectable one that you were talking about, have you seen that before?
Only like in pictures, videos, not in person. It's going to be mainly a combat medication.
I watched a lot of military guys in the Navy before that came out, they just carry around tampons.
Oh, interesting. Okay. That would work as well. I prefer, and I have in my first aid kit for camping and stuff, you can get the impregnated bandages. So it comes in a roll. It's already impregnated with like quick clot substance, and you can bandage the wound, and it'll help stop the clot that way as well. One of the first generations of quick clot that came out had to be pulled from the market, and then like the second generation was better. It was because it caused a thermal reaction. And these things are causing reactions, and it got hot, and it was causing local burns. So that's one thing you might hear about. It doesn't really happen anymore. They're on like their third or fourth generation of quick clot.
Is there any data relating to allergic reactions to these things?
No, I haven't seen anything about it.
Yeah, we got that stuff out in Sandpoint, it's called C-Lox.
Yes, Celox is one of them. That's a cellulose one, and that helps form a fibrin clot in the wound. Tourniquets. Who here has ever used a tourniquet in a real life scenario? Went well? What kind did you use?
The little,
Windlass one with the
the
rod?
one that just turned, yeah, we had a guy out in the Holy Family that was, cutting something down with a box cutter, lacerated his AC, completely pointless. By the time you put a bandage on it, bled through, and we just went right to the tourniquet.
Okay.
And I mean, it slowed it down, it didn't slow it down that much.
Mm-hmm. Where'd you put the tourniquet?
We put it all the way up
Kind
here.
of mid-humerus? Okay. And was it this kind, or was it the windlass with the rod you turned?
No, it's that one.
That one right there? Okay.
We
Yeah.
use
The windlass rod one?
the
Okay.
cap.
Yeah. That's one I have in my first aid pack at home. The windlass one. Have you ever put it on yourself, tried it?
Yeah.
Pretty friggin' effective, aren't they?
This guy pulls it so tight, you have to turn the windlass.
Sweet guy. So the thing I like about the windlass over this one, if I was to give my preference, and I don't own any stock in anything, at least I don't think I do, I wish I did, but. So the windlass one, when you're taking it off, when I'm taking off in the ER, because you put them on, easy, great, stop the bleeding, job done, right? But now when you bring them into us, myself and the surgeon have to figure out how long has it been on. You know, you definitely should have wrote the time on, right on the tourniquet, write the time, write it on the forehead. I don't care where you write it, just put it on there somewhere. And now I need to figure out how do I take this down slowly. And this one is not as easy to take down slowly. You'll see this one here says lift to release. The whole thing releases. What happens at that point?
Acid.
Yeah, I mean, what's been going on past the injury now? Anaerobic metabolism. So you got all this acid and toxic chemicals from cellular processes build up. And those things tend to cause arrhythmias. And so if we loosen these things up too much and they've been on for a few hours, you can get this sudden surge and potentially have an arrhythmia. Never seen it before, but we keep that in mind and don't do it. So I like the windlass ones because I can undo the thing and, you know, let one turn down over about 10 minutes.
I know this style right here is, at least the ones I played with, are inherently weak. We switched
Yeah.
over to the cat tourniquets.
Yeah.
I figured I'd try it.
Yeah.
Yeah, it broke real fast.
Oh,
So we had
this
two
one?
of them. Yeah, we had
Okay.
two of them. So I was like, well, maybe it was just the ones. I tried the second one, and sure enough, just after losing the pulse, it broke, and then releases everything.
And the windlass kind, you can easily make in the field, you know, with a shirt sleeve and a stick. It's very easy. So I like that kind a lot. Makes sense. Here's somebody putting one of these on the wound. Typically you want to go just above the wound. If it's like in the antecubital, it might be even harder, so then you go for the pressure point and go midway. But you just think, wherever I put it, I'm going to cause cell damage and cell death all the way below it. So try to kill as little tissue as you can. Okay. With that said, do you know the general odds of getting an amputation if somebody gets a tourniquet put on?
Pretty minimal, isn't it?
Very low. I don't like percentages, but very low. Okay? So there's military data now coming out with the more tourniquets being used, especially with Afghanistan, Iraq going on. They're using more stuff like that. And they really started looking at the data behind these things, and this is why it's really come back full force. It fell out of favor for a while. People thought they're barbaric and were killing extremities and arrhythmia potential and blah, blah, blah. It's a pendulum swing, just like everything in medicine. Now it came back, and tourniquets are great for the appropriate setting, where you can't stop the bleed with direct pressure and the other things. But you want to put it close to the wound as you can, time it. They can stay on for 2 to 6 hours. 6 hours generally is when you start having permanent cell death. And typically, these people walk away with normal limbs and virtually no neurologic deficits.
You know that they use the Boston Marathon as
Yes.
a big win for tourniquets?
Yes, they did.
Where so many people got hurt, they used less blood on that one versus, I think, a Malton, where there was only 2 or 3, or the police officer.
Yeah, that's correct.
They didn't use a tourniquet on him, they used more blood on him alone.
Yeah.
Versus everybody at the Boston Marathon.
Correct. And some of the best photos from the Boston Marathon just so happen to have people using bystander tourniquets.
Yeah.
Yeah, there's one of the runners holding a lady's leg up. I think she was a lady, and somebody already had a shirt or something wrapped around a tourniquet, and then there's the guy being wheeled away with his leg blown off, tourniquet on him. So it really was like, there it is.
Mm-hmm.
Any publicity, right? But yes, they are very effective. In the ER, I've never used a tourniquet because I have blood pressure cuffs that I can control precisely. So I'll get a manual blood pressure cuff, put it on, jack it up so the blood flow decreases enough where I can now explore the wound and find what the problem is and fix it. But it's just like a tourniquet. Allows me a little more control. What's your goal? Here's a good one with the tourniquet. What do you really want the goal to be? Do you want no pulses distally? Some people, the education on a lot of these things is turn it till there's no pulses, right? But what do we really care about? Yeah, reduce it till you can manage it, or till it's nothing, you know. But if they still have pulses distally, man, freaking-tastic. That's great, right? If you still have pulses in your feet, but yet you've decreased the bleeding to totally manageable, you can just put direct pressure and you stop it, that's wonderful. I'll take that any day over no pulses. Yep. All right, tourniquet, leave the tourniquet in place, da-da-da-da-da. Yeah, don't take it off in the field, bad idea. We already talked about this. Okay. You guys are not going to be, you're going to be upset if we get done early?
Horribly,
Horribly?
He'll find something for us.
Yeah. Oh, you will? All Alright, so let's be careful. So, coffee grounds, black stool, why does blood get dark when it's in the GI system? There you go, yeah. As blood's digested, the protein breakdown turns the heme, the iron in the blood, black. That's it. That's simple. So now in the GI bleeds you see in the future, you can look at the poop or the vomit and say, oh, this blood is coming from higher up in the GI system versus lower. You know, people that wipe and see bright red blood, internal hemorrhoid, external hemorrhoid, anal fissure, it's not killing them, it's fine. Okay? If they now have purplish, maroon colored, I know it's probably come from higher up in the colon. If it's black, tar, melena, probably an intestinal or ulcer bleed from up high and it's being processed all the way down. So very color-wise tells you where it's coming from. Black tarry stool is called melena. Let's see. This is a good one. So vaginal bleeding for the guys out there. This is always a tough one for me. If a patient calls for vaginal bleeding, because you get a lot of those calls, okay, miscarriages, things like that. How much blood is too much blood? If a female is bleeding vaginally. I spent years like, I don't know how much blood is too much blood. This is awkward. But typically the teaching in gynecology is a pad an hour, like not a tampon, like a pad. Okay, and if you don't know what a pad is, go check your girlfriend or wife, whatever. But ask them what a pad is. Have them show you a pad, and they're thick. And if you can soak, not just like have red blood for blood, soak a pad an hour for 3 hours, that's pretty big bleeding. Okay, so that's kind of my measure for the gynecologist what too much bleeding. Does that make sense? So if somebody's saying, I've had vaginal bleeding for 3 days, my next question is, how many pads are you going through? And I start narrowing it down. Okay, are you soaking the pads? Are they completely soaked within an hour? Yes, okay. Pretty good bleeding. Now it's, are they pale and tachycardic? Then you'll kind of answer your own question. Blood in the urine, quick note on that one. Blood in the urine is complicated because most likely if they have a lot of blood in the urine, and there's pink urine, who cares, right? A little blood in the urine. In the EMS world, I don't care. But if they are frank blood, like there's just blood coming out of their catheter or their penis or whatever, most likely that's cancer later in life. If it's a trauma patient, really different, trauma, kidneys, urethral damage. But most likely you're only going to see frank blood in the urine from an elderly male with prostate cancer. And they might not know they have it. This might be the first thing they have. Yeah, we talked about that. Head injury, direct pressure, blah, blah, blah. That picture is interesting, is the guy obviously had a chin injury where he probably hyperextended his neck back. Alright. Avoid compressing the eye globe. That's fairly self-explanatory. Neck wounds. Okay. Don't wrap the neck up. Don't constrict their airway. Crush injuries. Typically those aren't going to be bleeding a whole heck of a lot. They're mainly going to be fractures. There. Informative, huh? So, management of these patients. Okay, attention pneumo. You haven't, you're doing IVs now. I highly doubt you've gotten to needle decompression already. Okay, good. So we'll skip that for now. So yes, fluid resuscitation. He talked about MAP. So you have your shock patient. You now know about shock. You know, physical exam findings. You're saying, oh, this patient's in shock. They're tachycardic. They're pale. They're a bit hypotensive. Their cap refills longer than 3 seconds. This patient's in shock. Okay. So now you're managing them. Let's say their MAP, you got your monitor. I'm not calculating it. The MAP comes back at 60. You listen to their lung sounds. Clear. You're not worried about fluid overload. They're not adjusting or anything. So you give a liter of fluid, maybe 2, reassess them, and now your MAP is 63 or 65. So really, what do? You're in the field, you're traveling, you get to the ER, you want to show them you fix stuff, right? Do you keep doing stuff? No. I'm a big fan of don't touch it if it isn't broken. And so you fix something, you got their MAP to goal, you didn't have to start pressors, the patient looks okay, they're talking to you. Could they still be hypoperfused, pale? yeah, that's totally fine. That's not gonna go away for a while. But you've got their MAP to goal, they're talking, they're making sense. Don't do anything more. Maybe have the bag of fluids still hung. You can give them a little bolus of 500 if they drop below again or they look a little worse. You're good. Don't worry about it. Okay? I'll just watch patients and keep working them up and not keep messing with them. Hold off on the meds and fluids if you don't need them. Okay? Just keep them warm and comfortable. The permissive hypotension. So the whole blood pressure 80 to 90, again, you're going for the MAP, so don't worry about it. People will get really hung up on blood pressures, even you in the future, when you're out running stuff and picking up patients. You'll pick up that person who looks sick and they'll have a blood pressure of 88, 95. It will make you nervous. You're not used to seeing people with blood pressures less than 100. People get nervous all the time with it. ER nurses, sometimes providers, urgent care providers will get pretty nervous with low blood pressures. Unless they're symptomatic. It's kind of like, all right, well, we'll figure out what's causing it and go from there. You're thinking more in the lines of how does this patient look, how do they feel, what symptoms are they having. Don't worry about the numbers. You got a question?
Yeah. Maybe I missed it. Is there a limit to our map? I mean, what are we looking for a good number on our
65.
65?
Yeah.
Isn't that a normal patient though, 65?
Yeah, that's per fuse.
Yeah.
I mean, you're not going for like much over that. If you hit 65, you're good. Let's say you have a severely hypotensive, unresponsive patient. You had an initial MAP of 50, and you gave a bunch of fluids, and they're still not better. They still look horrible. You're starting Levofed or a pressure in the field, and you're really thinking this guy's like, he's circling the drain. He's horrible. And you start your Levofed. Your goal is an MAP of 65. No matter how they look, at least, as long as they got a heartbeat, they may still remain unresponsive and looking crappy. But you're giving fluids, you're giving pressors. If you can get that MAP to 65 and keep her around there, that's good. Job done. Make sure their airway is good.
What was your take on that podcast when you were talking about doing the fentanyl with no perfusion?
Oh yeah, I think that's great. So if you have a patient who their main problem right now is they're just freaking out. Like, let's be honest, some people, the main call is they have some sort of illness going on, but their bigger issue right now is they're absolutely freaking out. Perfect case, COPD patients who are hypoxic at 88%, wheezy everywhere, and they're just tachycardic and they're freaking out because they feel like they're dying. They're suffocating, right? It feels horrible. It would cause horrible anxiety. I will give the regular COPD medications, but I also give Ativan, which theoretically is completely contraindicated, right? You want to keep their breathing going well. You're not going to sedate them. That's insane. But their bigger issue right now is that they need some breathing help, some medications to open things up. But if I can take away the anxiety of it, everything's going to work that much better. And so a lot of COPD patients who are freaking out, I'll give a dose of IV Ativan. Not sedate them, not put them to sleep. They'll still be awake, but they'll be chilled out. They'll stop freaking out. All of a sudden, the BiPAP's working. The nebs are kicking in. They're feeling great. Everybody's a winner. And so if you think in the field that this person doesn't need pressors, their MAP is good, but they're just hurting from their fracture, heck yeah, I give fentanyl. Because that freaking out and anxiety is going to cause bigger issues for you anyway. Fluid resuscitation, there really is no particular number regarding shock of how much fluids to give a certain person. The current bolus recommendations, anybody know them?
20 milliliters per kilogram?
Yeah. For like kids, we give 20 per kilo. When you're talking shock and stuff like that, we do like 30 per kilo. Bumps it up a bit. So that's where I will use numbers in regards to how much fluid I should give a trauma patient who's breathing okay with no CHF going on. I'll start at 30 per kilo. And that's your first bolus, and then you reassess. Obviously, large bore catheters, if you can get 2 of them in, great. Temperature control, like they mentioned in the podcast, very critical. Keep them comfortable. Not overly hot, but warm, comfortable. Then you don't want them cold. They're already losing blood. They're anemic. They can't keep their body temperature, and they're now in the winter in the back of an ambulance with their shirt off. They're
Would
getting
you give
cold.
them warm? Because we have some of our same beds on boilers.
Yeah, I mean, if it's cold out like this and they're hypotensive and they look shocky, warm fluids is fine.
I've got a quick question
Yeah.
Travis, about that. I've heard paramedics say that warm fluid really doesn't work. Have you guys seen it work for sure?
Fluid's fluid. Yeah, volume resuscitation. The thing with warm is how the body might respond to it. So while the patient may be kind of cold, if those arteries sense that now there's too much warmth in them and they may dilate, because what happens in the summer when you're at the baseball game, you're running around playing softball, whatever, and your body's overheated? You sweat. So what's happening to the peripheral vasculature? It's like a radiator. It wants to disseminate heat. So it's not going to keep things in the core. It's not going to constrict. It dilates, lets all the blood flow get out to your radiators, and it disseminates heat. So everything's dilated. That's why your fingers in the summer get swollen, and the rings feel tighter. Because everything's dilating, capillaries are leaking fluid, you're radiating heat to get rid of heat, and so that's why people may say, I don't know about warm fluids. Will it dilate things or not? That's really not an issue. You're resuscitating in the fluids. Would I just keep giving warm fluids? No. Maybe give a bag, but then I'd give room temperature. Just keep them warm with a blanket. So last slide. Okay, obviously, it's a small summary, but the gist of it is treat the patient, know what signs you're seeing, put it all together, because the puzzle will make sense when you start putting things together. Okay, if you have that bradycardic but hypotensive, that doesn't make sense right off the bat, because if somebody's hypotensive, the natural body response is to jack up the heart rate to balance things. Everything's a balance. Okay? And so if it's not balanced, that means something's amiss. So if you're hypotensive and bradycardic, that's the neurogenic side of things. Otherwise, you expect to be tachycardic with hypotension, and that's every other kind of shock. Anaphylactic shock. Okay, you saw it mentioned there a little bit. So what happens with a severe allergy and anaphylaxis? Obviously, I'll take away the whole lip swollen and the airway closes. Okay, that's done. So what else do we see with anaphylaxis? Okay, vasodilation. Where?
Everywhere.
Everywhere. So what happens in the summer when you vasodilate? Swelling, fluid, right? What happens to an anaphylaxis patient when they're vasodilating and all their cells, their mast cells, the allergy cells are bursting? They release histamine, and all these cell contents, and all these cells are breaking, so that's why everything swells. You're getting all this extra fluid in your skin and tissues where there usually isn't fluid. It's from all these cells breaking, which then make the capillaries release all their fluid and break down. So all your fluid is going into your skin and tissues instead of being in your vasculature. That's why your blood pressure tanks. All the fluid's in the wrong spot. Distributive shock. Distributed the wrong place. Okay? And that's not the kind of fluid you can just shove back into any cells into the vasculature. You're not treating the fluid in anaphylactic shock. You're treating the airway and the blood pressure and just keeping them stable, managing the airway. And you can do repeat doses of epinephrine.
So the thinking of, because you're vasodilated, you want to get fluid in those veins now. You know what I mean? That's done. That's done.
Yeah, so you can put more fluid in anaphylactic shock. If they're hypotensive, you're going to give epinephrine and some fluids. So you're going to be very judicious in how much fluid. Again, going for that MAP of 65. Well, the fluid's now in the tissues, so you need a little more in the vessels so the tissues can slowly reabsorb things. But now what you don't want is as you're treating the shock, and all that fluid is slowly being reabsorbed, now you're going to fluid overload them. So again, only fix it if it's broken. So an anaphylactic patient, I'm all airway. I had a lady last week, one of the worst anaphylactic patients I've seen in years. She ate something while cooking turkey dinner the night before Thanksgiving, and at 3 in the morning, ate something, and within seconds just started itching, puffing up, came into the ER, everybody's freaking out, and walked in the room, and I mean, not kidding her, everything was swollen, just edema everywhere, lips, everything. And while she looked horrible, first thing I did was, she's talking to me, her voice wasn't muffled, so I knew the tongue was okay. They're talking blah, 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 blah. Bad scenario. Get the intubation stuff ready, because this might be the worst case of your life. If you don't have to intubate an anaphylactic patient, it's going to be a hard intubation, potentially a code, and you lose them. It's not the easiest patient to cut the neck of either, right? feeling swollen, you know where you're cutting. And so my main thing with her was, I don't care about the swelling in the face, I cared about her mouth. So quickly she stuck out her tongue, looked normal, looked in the back of her throat, looked normal, and her voice was normal. Fantastic. I'm not cutting, I'm not intubating, I'm giving epi, along with all the other meds I can give for allergies. And I constantly rechecked her every couple minutes, had her talk to me, open her mouth, show me her tongue, have her give me thumbs up, thumbs down, and getting better, worse, same. And she's getting better, plateaus, and then says, starting to feel like my tongue's swelling. Epi again, better, plateaus, epi again. So it's just reassessing the patient. Was I watching the timer of when the last epi was? Nope. I didn't care if it was 5 minutes ago or 20 minutes ago. If she's getting worse, I'm giving her another epi. So just keep treating the patient. That's like every patient. Cool? That's it. Any other questions?